I don't know about you, but I feel like an open festival, but instead of having those music world stars and celebrities, we do have those celebrities, true celebrities of the therapy world. It's so difficult to actually give them the proper intro, bearing the incredible commitment and scientific input in mind, especially considering the next speaker, with regard to depressive disorders, anxiety disorders. Actually, Professor needs no introduction. Yesterday, I had the pleasure of actually getting together with Professor in person, at the foyer. I introduced the Professor. Professor introduced to me, and I thought, if he is actually aware of how long-standing relationship we have, even though we actually had met yesterday, because I have this, case formulation for my June exam, and actually the name of Clark keeps popping up in my research and my studies on and off, back to back, and therefore I would like to introduce Professor Clark to start this lecture proper part. Let's give a warm welcome to Professor David Clark.
Wow, that was fast. Great, thank you very much. So it is a great pleasure to be here with you today in Warsaw. I am going to be talking about the mass public benefit that can be achieved by increasing public access to psychological therapies. And my main argument will be that all of our nations need to invest more in psychological therapies because it transforms the life of our people and it grows our economy. So it's just stupid not to do it. So that's the end of the lecture. You can go and get your coffee now. Great. So things have changed in the last few decades. There's been an enormous amount of research in psychological therapies. Some therapies that we used to do have turned out not to be very effective. Some other therapies that we've been doing for a while turn out to have accumulated quite a lot of evidence. And some new therapies have also collected evidence. And in England, we have an impartial government body called NICE, the Institute for Care and Clinical Excellence, which is charged by the government in order to look at the evidence for the effectiveness of interventions across the whole of medicine. And when it thinks there's overwhelming evidence for doing a particular thing, it recommends its use in the healthcare system. And sometimes it also says, stop doing something because it's clear it's not helpful. Well, starting in about 2004, NICE started issuing guidelines on the treatment of mental health conditions, and those early guidelines made it very clear that for common mental health problems, so depression and all the anxiety-related disorders, including PTSD and OCD, short-term, and by that I mean up to about 20 sessions, psychological therapies should be offered as first-line interventions because of the strong evidence for them. And those recommendations were very popular with the public. There are multiple surveys done in European countries and in North America that have asked people, if you had a choice between an evidence-based psychological treatment and an effective medication, what would you prefer? And some people, of course, say, give me the drugs. But in a ratio of 3-to-1, the public expresses a preference for psychological therapies. But before the program I'm about to tell you about started in England back in 2007, that wasn't what the English public were getting. Only about 5% of people with anxiety or depression were getting an evidence-based psychological therapy. Of course, some others were getting some psychological interventions, but it wasn't evidence-based. And I think it's fair to say there was no country in the world where the public was getting what it wanted. There was nowhere where psychological treatments are more commonly available than medication. So in England, we started a program to try and change that. But I should first talk about what do we mean by evidence-based or empirically supported treatments. Everyone knows that when you're emotionally distressed, it's wonderful to have a friend. It's wonderful to have someone who's warm and supportive, encourages you, and is non-critical. But you don't need a professional for that. If we're looking at professionally delivered treatments, we've got to do better than that. And so the empirically supported treatments are essentially treatments that do better than that general, very important emotional support, although they include that. Here's an example of one from our group. It's trauma-focused cognitive therapy for PTSD, and it's a trial showing that it's doing significantly better than emotional support in terms of supportive counseling, and both of them are doing better than no treatment. So these are the sort of treatments we're talking about. So in England, we started a program which was called IAPT, Improving Access to Psychological Therapies, but is now called NHS Talking Therapies. And the argument was that the reason why the public isn't getting access to the treatments, or one of them, is we simply don't have enough properly trained therapists. So it started by training now up to about 11,000 psychological therapists, and they all followed the same training curricula. So if it was CBT, there's a national curriculum for it, and they're taught the particular evidence-based interventions for different conditions. And when they've completed the training, they only pass the course if they demonstrate that they have the skills required for each of those therapies in live recorded videotapes of their therapy sessions. So it's a competence-based training. The training involves 1 or 2 days a week in a university, getting clinical workshops, and all the rest of the time already in a new clinical service, an IAP service, where we will guarantee that all the patients you see have the clinical problems that you are being trained to treat. This close integration of the training and clinical practice is really very helpful and very important. We've had many attempts to train therapists in the past where they've come on a training course and then gone back to a job where they see very few of the people that they're trained to treat. And that doesn't work. So we created new psychological therapy services, anxiety, care services. So nice in that for the more mild to moderate cases, a lot of people will do well with what we call a low-intensity intervention, such as guided self-help or computerized CBT. But if they don't recover with that, they're stepped up to more conventional face-to-face once-a-week therapy. And for the more severe cases, and also for PTSD and social anxiety, they go straight to the high-intensity intervention. It's very important that the therapists and the services all get regular clinical supervision, and that it's an exciting place to work, so they get continuing professional development opportunities throughout the time they're in the program. And we decided we would try and measure the clinical outcomes of everyone who has a course of treatment, and in a unique exercise in public transparency, we would publish that data. If you Google now, NHS Talking Therapies annual report, you can see in this room the outcomes of every single IAP service last year. Okay. Full public transparency. And of course, the idea is if we collect that data, we can learn from it and we can sort of improve the services. This initiative was based obviously on sound clinical arguments, and it was my job to present those to the government, but also crucially on economic arguments, and that was done by Richard Layard, who's on this slide as well. So what were the key arguments? Well, the first one was just to point out to government that untreated anxiety and depression is very expensive. The World Health Organization estimates that untreated anxiety and depression reduces the size of all of our economies by about 4 percentage points. In Poland, if your economy was 4% bigger, that's a lot of money. How does it do that? Well, if you're anxious or depressed, you may not be able to work, and so that affects the economy. But also, if you are working, your mind is often somewhere else on your worries and your concerns, so you're less productive. That's what we call presenteeism. But that big loss to the economy is unnecessary because we know already there are effective psychological treatments in research trials, but also it turns out that it is possible to train people in routine practice to get very similar results to research trials. Our first good evidence for that was from this slide here. It's the scene after a terrorist bomb in Northern Ireland on the 15th of August, 1998, where 29 people and 2 unborn children were killed and 531 people were severely injured. And many more people saw things that day you should never see in your life. And there was, of course, an enormous amount of post-traumatic stress in the community. But the clinicians there hadn't been taught how to treat it. So our team from Oxford went and trained them in trauma-focused CBT. And then we set up a clinic with no exclusion criteria. Anyone could come in, just drop in for therapy. But we weren't sure whether they would stay. We gave them a simple measure of anxiety and depression every time they were seen. So if they didn't come back, we'd know how they'd done when the last time we saw them. And what we found there is that we could train people to get results just as good as in the randomized controlled trials. And we could get data on everyone with a simple system. So in principle, you can do it. And the last bit of the argument was to say, and overall, it doesn't cost you any money. Because as long as you can get the outcomes you'd expect from the research literature, then you will save a lot of money in other healthcare. People have less physical healthcare costs. And also, as people get back into work and are more productive in work, you'll get an increase in tax revenues, less people on state benefits. And we argued that together, that more than covers the cost of the system. That was outlined in our book, Thrive, if you want to see the arguments in great detail, and those are just the different international translations. So those are the arguments. How were they advanced? Well, there was really a very careful process of engaging with government. We created a pamphlet which was distributed in one of the national newspapers one Sunday. And we also worked with patient groups to ask them whether this is what they wanted. They said, yes, we do. And so they produced their own pamphlet in their own words, asking for the same thing, called We Need to Talk. And we agreed they would release that on the Thursday in order to control the English media for a week. That got the attention of the government of the day. Blair and Brown were the 2 prime ministers that covered that period, and they made a commitment to start the program if they were elected in the next election. They did get elected in the next election, and then immediately said no. That's big. I know you've given it a lot of evidence, but can't you do a few pilot studies? Which is a reasonable point. So we did a couple of pilot studies, and they worked out very well. So at that point, the government committed to expanding the program, rolling it out in a phased way across the nation. The investment was small initially, about 38 million euros in a year. It is now about just over €1 billion a year. And it has been supported by every English Prime Minister since then. They've all expanded the program, except for one. You may have noticed that in England we change Prime Ministers quite often. And we do have one, Liz Truss, who wasn't in office long enough to expand the IAP program. Turns out 40 days isn't quite long enough. So what has it achieved in this period of time? Well, we set a goal looking at the research literature and said that if we develop the train people well and deliver the treatments well, we should be able to get 50% of people to fully recover from both their anxiety and depression. And about 70% should show marked improvement. As you can see in this slide, that's where we are at the moment. There's a 50% line, the target, and we've been at that level or above in terms of recovery since 2016. And we're pretty close to our 70% of people improving. But you can see we didn't start that way. Although we had really good training courses and good people applying for them, initially our outcomes were less good than we expected. And if we hadn't been collecting, and if we hadn't been collecting the outcome data, then we would still stay at that lower level, a bit less than 40%. And as therapists, we would be blissfully ignorant. But round about 100,000 people each year in England who we could have got better would not be recovering. But because we got the data, we could study what was happening. And we found that some services were already doing a lot better than others. And we looked at what were they doing different. And we learned from that, and we fed that learning back into the system. And so, as you can see, we really ended up with the best results. What were the sort of things that we learned? Well, one of the first lessons was to do with ensuring you follow clinical guidelines in terms of what treatments you should offer. So NICE, having looked at all the randomized controlled trials, had indicated that CBT could be offered for all the anxiety disorders and depression, because it has a good evidence base in each of those conditions. It said that there wasn't good evidence base for other psychological treatments in the anxiety disorders, except for in PTSD, where EMDR also has an evidence base. So we offer both CBT and EMDR for PTSD. But NICE said, if you look at depression, it's very different. There, CBT is effective, but so is brief psychodynamic treatment, so is interpersonal psychotherapy, so is couples therapy. So we offer all of those in the services. We're just following the clinical guidelines. But of course, some therapists, when they're on holiday skiing, ski off-piste. And sometimes when they get back to the clinic, they ski off-piste in their therapy, and they do something else. And that happened quite a lot in the first few years. So we've got a natural experiment. We can ask, if clinicians do not follow the clinical guidelines, what happens to the outcomes for their patients? And whenever we've looked at that, we've always found that we get better outcomes when we follow the clinical guidelines. So, for example, NICE recommends counseling as well as CBT in the treatment of depression. And we have a lot of counseling, and we find that the outcomes are just as good with counseling as CBT. So NICE was right. NICE does not recommend counseling for generalized anxiety disorder. But many of my counseling friends say, but we do well with people who worry a lot. And it turned out they were right. 48% of people with generalized anxiety disorder recovered with counseling. But what they didn't know, until we looked at the data, is that it is 58% with CBT. Similarly, NICE says for PTSD or social anxiety, don't use these low-intensity interventions like guided self-help. Just go for the high-intensity intervention. But some of the services were using some of the low-intensity interventions. And the data here shows that patients suffer if you do that. You can see the recovery rates are much higher for the orange bars, which are the high-intensity treatment, than for the blue bars, which are the low-intensity treatment. This is an analysis of 1.3 million patients, and we've statistically controlled for all possible confounds. So it's really true. It turns out that it's not just giving the right treatment that's important, it's also how you set up your services. And we discovered this with some analyses where we compared the services that do really well in outcomes with the services that do less well, and looked at what's different. The first thing we found was to do with the assessment that you have. Those services that are very good at identifying in that initial assessment the core clinical problem, is it PTSD, is it depression, is it generalized anxiety, get better outcomes, presumably because they make sure people get the right treatment straight away. We also find that how long you wait before starting treatment is important. And you see that on this graph here. What we've plotted here along the bottom axis is the average number of days you have to wait between your assessment and starting treatment in a given service. And then up on the other axis, we've looked at what's the probability that you will recover in that service. And each blue dot is all the patients treated in an IAPS service in a year. So each blue dot is about 5,000 patients. And what you find is that if you look across the line, it doesn't really matter how long you wait on average at the beginning of your treatment, as long as it's no more than 6 weeks. But if on average you're waiting longer than 6 weeks, although the treatments are the same, your chance of recovering has declined. So this led our government to say we want everyone to be treated within 6 weeks. We also found that just like with drugs, there's a dose-response effect. Those services that give an average higher number of sessions get better outcomes. But the average doesn't have to be very high. On average, around about 10 sessions seems to be optimal. But of course, we have some patients who've got 20, 30 sessions and some many less. Another thing that we found is that if the service is in a socially deprived area of the country, on average, it gets slightly less good outcomes. And you might say, well, why is that? Maybe psychology doesn't help you very much if you're living in difficult circumstances with very little money. Alternatively, if you're living in difficult circumstances with very little money, maybe you also don't have access to a good psychology service. That's part of your deprived area. You can statistically distinguish those two ideas by controlling for these quality factors, the first bullet points, and then seeing once you've statistically controlled for them, is there still a predictive effect of social deprivation? And what you find is that it more or less disappears. So it is to do with the quality of the service. And I'd like to give you a slightly comical illustration of that. So here you have the outcome from two areas in England, which are next to each other geographically. They are both served by one very high quality talking therapy service. Windsor is where our new king, King Charles III, has his weekend castle. And you will not be surprised to hear this is not a socially deprived area. It's at the 4th percentile for social deprivation in the country. But right next to it is a place called Slough, which is one of the most socially deprived areas in the south of England. It's at the 68th percentile. But you'll notice both of them have outcomes better than the national target. And if there's any difference, it slightly favors Slough. So we know that being a king is a very stressful job. And if King Charles felt that he would like some therapy in the IAPS service, we might suggest he suggests that the chauffeur drives him a bit further down the road to Slough. So this really brings us on to a very important topic, which is inequalities in healthcare. And obviously, in all of our societies, we want to have healthcare fair to everyone. And if you collect data on everyone, you start to spot inequalities. But the wonderful thing is you know about them, so you can now work to change them. So here is an inequality that we spotted in our data. Back in 2015, we saw that the recovery rates for people from the white population were considerably higher than people from the black population or the Asian population. That's not okay. But although that was a national picture, when we looked locally, we found some services that were doing very well with those minority ethnic groups. And we looked at what they were doing. And we put it into what we call a positive practice guide that was distributed to all the services. And you can see several years later, we've abolished the difference in outcome between the black population and the white population. They're doing equally well. Everyone's getting better outcomes than before. And the drop to the Asian population is much reduced. And we will get rid of it. So that's the magic of the data. You understand problems you didn't even know you had, but it's good to spot them because then you've got something you can work on. So this then takes us to other things that you can do with the data. So currently in our services, we're treating 670,000 people every year, and we're getting outcome data on 99% of that 670,000 people. So this is a large data set. It's about 8 million treated patients at the moment. So you can do some pretty interesting analyses in it. And you can look using what we call latent profile analysis at seeing if you can identify subgroups of people who don't do very well. And we have identified, or Robert Sanders has identified, a subgroup which he calls LP7. He's a statistician. And they don't have any particular clinical diagnosis. But so they cover all the clinical diagnoses. They have pretty high scores on anxiety and depression. But they also have some employment issues. And their outcomes are not the 50% average. It's more like 20%. But once we've spotted them, we can then think, well, what can we do? What can we do that's different? And we thought, well, if we bring into their treatment also a employment advisor who is very well informed about psychological therapies and knows what you're trying to do with the psychological therapy and what the advisor can add to get someone back into work and feel comfortable at work, we thought that might help. And so what we did is we then got the algorithm from Rob, and we identified at assessment everyone who fitted that profile, and then offered them the enhanced treatment. So this is not a randomized control trial. Some people accepted it, some people didn't. But you can see it looks very promising, because of those people who accepted the treatment, they're at 47% recovery, although they're still in this group. So this is some of the wonderful things you can do with the data. Of course, I'm sure you all know that one of the biggest areas of research in psychotherapy is internet delivery of treatments. And so we're bringing those into the services as well. And this is an illustration of internet treatment of cognitive therapy for social anxiety disorder. I'll be doing the workshop on it tomorrow. And we have developed an internet version of the treatment where most of the learning that patients will achieve in therapy, they can do studying detailed modules on the internet and lots of video illustrations of some of the things to do. But they still have a therapist who supports them through the program. But the therapist's time is much less. And what we found, this graph here shows it, is a randomized control trial where we compared the standard once a week, 90-minute therapy session with the internet treatment. And the blue line is the standard therapy. And what we've plotted is your social anxiety coming down against increasing numbers of hours of therapy. And you can see that for the group as a whole, they need every hour of therapy. They're still showing improvement between the 17th hour and the 18th hour of therapy. But if the same therapists now support people with the internet program, you can see they get to as good an outcome with much less therapist time. You save about 60% of the therapist time. And we're now making this internet treatment available in the Talking Therapy service. And we find that in routine use in the talking therapy services, they get just as good outcomes as our expert clinicians using the program. So in a recent study, we found 60% of people in the talking therapies program completely recovered from their social anxiety and depression, and 81% showed marked improvement. So in this short talk, I can't take you through all the details of the different types of treatments we're talking about, but at least for the ones that our group has been developing, which are forms of cognitive behavior therapy for PTSD, traumatic bereavement, panic disorder, and social anxiety disorder, we have a free therapist resources website, which you're very welcome to use, and you'll see multiple video illustrations of the different key techniques. You'll also see our therapist manuals there. You can download it all for free, plus questionnaires. At the moment, there are therapists in 176 countries using this program. I'm very disappointed because there are 195 countries in the world, so we've got 19 still to go. And around about 30,000 therapists every day are using it. So you will join a big international community. And do give us feedback on what you don't like, as well as hopefully some things that you do like. We're always adding to it. But it's your resource and it's free. So I think you'll have gathered from my talk that getting the data is really important. That's really been the stardust in this English program. It was supported initially by a left-wing government. Our administration has moved all the way over to the right during the period of the program. But every government has been happy to increase expenditure on the program. That's very unusual when you get these political changes. But it is because we've been willing to report the data, and they've been able to see that the money is worth spending because people are getting better. And you can see we've learned a lot about how to do things better. So how do you get this level of outcome data, 99% of patients giving you the data? Well, there are several ingredients. The first one is you really do need to give these measures every time someone's seen, because otherwise if someone drops out of therapy, you don't get the end of treatment data. And they're the people you really want to know about. You also need to make it help the therapist not to see it as a bureaucratic exercise. So you need to train your therapist to actually look closely at the questionnaires and use not just the total score, but the individual items to plan what you're doing in therapy. You also need, of course, patients to see that it's valuable. So that means first that the therapist pays attention to it, and they can see graphs of progress and things. You also want to make sure that it doesn't waste any therapy time. So people do not complete these measures in therapy sessions. Instead, they just get a text message on their mobile phone, they click a link, and then complete the questionnaire on that. So there's no real burden. And lastly, it's important how you present the results. So we adopted what we call SMART metrics for national reporting. So say your service treats 1,000 patients in a year, and 500 of them give you outcome data, and 250 of those recovered. You might say, okay, our recovery rate is 50%. It's half of the people we got data from. We say, no, we will publish your recovery rate as 25%, because we're interested in only demonstrated recovery. Now, you might say, that's not fair, because some of those 500 that you don't have data from will have recovered. That's true. But this turned out to be a brilliant behavioral intervention, because within 10 months, all of our services were reporting outcome data on almost everyone. So, just to wind up, the whole program was sold to government on the basis of research at the time, back in 2007, which indicated that if we could effectively treat people's anxiety and depression, it would save money elsewhere. But you might ask, but has that been true? And thankfully, we can now answer that question because you can use data linkage as we get clinical data on everyone, and we can link it to other data records to see whether the benefits that we predicted are observed. And that is the case. So, for example, we've shown that the talking therapies treatment reduces patients' subsequent number of admissions as outpatients or inpatients in physical health services. That saves a lot of money in the healthcare system. We've also shown that successful treatment in talking therapy services for depression, if you follow people up through their GP records over the next 3 years, they have less adverse cardiovascular events. That includes significantly less heart attacks and strokes. And then in the most interesting data published just a couple of weeks ago, we've found that if you follow people up for 8 years after their treatment in the talking therapy services, those in whom we successfully treated the depression have a reduced onset rate for dementia. So psychological and physical things are very closely related. And there's a lot of money you can save in your healthcare system because of that. But it's not just that. We said also we help people back into work. So on this graph here, you can see an example of this. We developed some new IAP services for people who have physical health problems as well as anxiety and depression. Say they've got diabetes and depression or cardiovascular problems and depression. And we call them integrated IAP services because we bring together the physicians and the psychologists. And we rolled them out earlier in some areas of the country than others. And in this graph, you can see the areas where we rolled them out early are the blue bars. The ones where we rolled them out late are the orange bars, and that's the control conditions. And what you find is that in those areas where we roll out the new services, this is an employment rate, more people become employed between pre and post treatment. But if you look at the same time interval in the areas which don't have those services yet, but it's similar patients, you see actually they tend to lose their jobs. And so it's having a beneficial effect. And thankfully, quite a number of other countries have expressed an interest in the talking therapies, and some have developed their own version of the program. Norway is perhaps the most developed. It now covers more or less the whole of Norway. And they have done some wonderful research. We've been collaborating with them, where recently, when they rolled out a new service in a particular area, they randomized patients to either treatment in primary care, standard treatment in primary care, including access to psychologists and psychiatrists, or treatment in the new talking therapy service. What they've already published is the fact that the recovery rate for people who are randomized to the talking therapy service was twice as high as in the standard primary care service. But the most interesting data, and it will come out in a few months, is they use the Norwegian tax information to also track people's income over the next 3 years. And what they found is that those people who were treated in the talking therapy service, their income improved in the next 3 years. Those people who are treated in primary care, it didn't improve. And so now you can calculate the extent to which talking therapies helps you grow your economy, put more money in the economy, by taking the difference in income between the two groups and then dividing it by the extra cost of the service. And the answer is 4. So if you put 1 billion zloty into your talking therapy service, the economy grows by 4 billion zloty. Pretty good. And this is not simply in Norway. We've also got data from Spain showing exactly the same effect, and in England. It's a very robust finding. This is the Spanish data. And so our Chancellor, the person who runs the Treasury, the Finance Ministry in England, looked at that data in November, and he very kindly gave us an extra 680 million euros to further expand the Talking Therapies service, simply because he's convinced that it helps his government grow the English economy. So it's not just transforming the lives of patients and their families. It's giving you all more money in your economy to do other things. Thank you very much.